Hey guys, it's John with NP Board Review. Hope you guys are doing great today. We're going to start with part number 2 of our study group board review. And I hope you guys saw part number 1, enjoyed it. Again, if you want a copy of this study guide that I'm using, I will leave a description in the box below. So if you guys do want it, go ahead and grab it. Remember, I'm not using this in the entire book. I'm not going question to question. I'm not stating their answer to answer. That is their right and prerogative to sell it to you. But I'm going to go over a few of these questions, go into a bit more detail what the book would, and try to make it a little bit more understandable for everyone. All right, so last time we left off on question number 9, which was a question about reportable offenses that we would see in the emergency department. This one in particular was elder abuse. And we're going to skip the next couple questions and then go on to number 11. So the question is, what is a good strategy for helping an elderly client overcome feelings of low self-esteem related to chronic illness and loss of autonomy? The answers are A, praise the client continuously for any activities. B, tell the client she has no reason to feel so depressed. C, provide opportunities for the client to make decisions. And D, encourage the patient to focus on positive factors. Now, this is a therapeutic communication question. And the way I approach therapeutic communication is the golden rule, which is do unto others like you would have done unto you. So let's look at these and see which one we would like to have done for ourselves if we were in the elder's position. So A, praise the client constantly for any activities. So that would be you in the room saying, hey, you got your underwear on. Hey, you made a dookie in the bathroom. That gets annoying. That's very condescending. Nobody likes that. When you're praised constantly, it becomes meaningless. So A is not the correct answer. B, tell the client she has no reason to feel so depressed. Well, if you're feeling sad, would you like someone telling you, hey, you shouldn't feel so depressed? Life is good. Get outside. No, that's not very respectful to the patient. We can discuss, an appropriate response would be, I see you're feeling depressed. Would you like to talk about it? Or can you tell me how you're feeling today and explore, that's more of a therapeutic approach versus you don't have any reason to be depressed. Go outside, dance in the flowers. That doesn't work. D, encourage the patient to focus on positive factors. So this one you might think is the correct one. You should say, yeah, you're depressed, but, sun's shining, birds are singing, flowers are blooming. Let's focus on the positive stuff. Again, it doesn't address what is going on underneath. It doesn't really get to the meat of the therapeutic communication. So that's why C is the correct answer, and C is provide opportunities for the client to make decisions. So we look back in the question, and the question is, what's a good strategy for helping a client overcome feelings of low self-esteem due to, then the keywords are chronic illness and loss of autonomy. So we're trying to get the patient or client to realize that they can make positive changes and choices in their life. We're trying to give them that autonomy back. So that is why C is the correct answer, because we are providing opportunities for that client to make good healthcare decisions. All right, or at least, I guess, good is a value judgment. To make decisions for themselves. That's what is good for the patient in their mindset, what they feel is good or not so good, because there's always shades of gray. All right, number 12. A 70-year-old male patient is admitted with right-sided heart failure. Findings that are consistent with right-sided heart failure include paroxysmal nocturnal dyspnea, increased JVD or jugular venous pressure, C, pulmonary venous congestion, and D, orthopnea. Okay, so this is heart pathophysiology. So let's pull up our handy dandy heart. I wish I like this picture, but such a low resolution. It just drives me crazy sometimes. But let's take a look at right-sided versus left-sided heart failure. And this is an important thing to really get a good concept of. In fact, I really, personally, I mean, I've been a nurse practitioner for 20 years. And up until I switched my practice to cardiology and was in cardiology for a couple of years, that it really then started to sink home. Oh, right-sided versus left-sided, and here's what it all means. Okay, so let's look at left. What does the left? Well, let me back up again. Let's just go through the quick little pathophys of what happens with the heart. Okay, so let's start with blood return. So blood has gone through the little capillaries. It's fed all the tissues it's going to feed, and it's on its way back up through the heart. Okay, and it goes back to the heart through the veins. And does blood pressure have anything to do with venous return? No, it does not. Because we lost all our pressure, pushing out all the blood to the capillaries. Okay, we no longer have any pressure coming from the left side of the heart, from the blood pressure. So now we're in the venous system. The venous system, as you know, is a low pressure system. We can stick IVs and do venipunctures in there all day long. It'll ooze a little bit, but it won't gush. It's not like you're puncturing a major artery. It's a vein. Okay, that's why we can take a triple lumen out of the neck, just hold pressure there for 5 minutes, and we're good. Versus if we accidentally stuck a needle in their carotids, we're going to be putting pressure on there for 30 minutes or more, possibly even doing a surgical repair, because, depending on what the blood pressure is. So keep in mind, blood returns to the heart through the venous system. Blood is pushed forward into the heart through this series of valves that are present in the veins. So we got these little valves pushing blood forward. It's pushing forward, pushing forward, pushing forward. Again, nothing to do with blood pressure. So it dumps all the fluid into the right atrium. Okay, the right atrium contracts, pushes blood to the right ventricle contracts, pushes blood up into the pulmonary artery. So this is the oxygenated blood going through the pulmonary artery, goes to the alveoli, comes on back through the pulmonary veins, dumps into the left atrium and coronary sinus is over here. Left atrium, coronary sinus. The left atrium contracts, pushes blood into the left ventricle. Left ventricle contracts, pushes blood out to the aorta. Okay? And that's where we get our blood pressure from. Okay, so let's think first about left-sided heart failure, what happens there. And I think left-sided heart failure is the heart failure we're all as nurses are most familiar with. Someone has a heart attack, or someone has what we call a non-ischemic cardiomyopathy. Their left side of the heart, the main pumping chamber of the heart, isn't squeezing very strongly. A normal ejection fraction is 50 to 60%. If you're squeezing at 20%, you're not pushing out as much blood that's coming in. Because remember, we're getting all this blood coming back from the lungs. So blood is sitting up here waiting to get it pushed out through the left ventricle. If the left ventricle can't squeeze very strongly, we're going to have a lot of residual volume of blood in the left ventricle. And the left atrium squeezes, it pumps it up a little bit more, and the left ventricle squeezes. But we're still getting this backup of blood. So the pressure inside the left atrium is going to start to rise. So we'll see an increased pressure of blood in the left atrium. And when that can't hold anymore, then we have an increased pressure of blood into the pulmonary veins. And when that gets filled up, we're having increased pressure in the pulmonary artery. And because we're getting this increased pressure, we're starting to see a lot of edema in the lungs. This is where we get our pulmonary edema from, because that lung tissue is trying to absorb all that extra fluid. It's not blood, but remember that when the blood cells stay in the blood vessels, but what happens to all the plasma if we have a large pressure force in the pulmonary arteries and veins, it is going to push fluid out into the lung tissue, into the parenchyma of the lung itself. And that's where we get pulmonary edema from. Okay, so now we have this high pulmonary artery pressure, and then we're going to translate to a high right ventricle pressure, a high right atrium pressure. We're going to see elevated pressure in our jugular vein, because blood now can't drain into the right atrium. We get 30% of all blood goes to the brain, so we have this big backup here in the superior vena cava, and then we have a backup of blood coming up from the inferior vena cava, and then that will translate to ascites, hepatic congestion, lower extremity edema. Remember, it starts from the heart. The swelling, the edema that we see starts from the heart and then spreads outward through the tissue. So, going down. So first we'll see, hepatic congestion, and then ascites, and then, when we're seeing +3, +4 lower extremity edema, then it's getting pretty dang bad, because it's had to work its way all through that. It doesn't just happen all at once. This is a chronic condition. Okay, so that's left-sided heart failure in its extremity, in the extreme. It will eventually get to be that bad, okay? But what if something happens only to the right side? Let's say the left side is pumping just fine. We have no problem. But the person had an infarct, had a heart attack that only affected the right ventricle, and the right ventricle isn't beating well. What's going to happen? Well, we won't have pulmonary edema because we're not getting enough blood into the lungs. So we have a reduced output into the lungs. That's then draining into the left side. So there really won't be any pulmonary edema. But what we will see, remember, this isn't pumping very well, so we'll get an increase in pressure into the jugular vein, the superior vena cava going up to the jugular vein, the inferior vena cava going down to the liver, we'll get ascites, and we'll get lower extremity edema. So you can get, right-sided heart failure with elevated JVD, elevated, large amounts of lower extremity ascites, of ascites, lower extremity edema, without the corresponding left-sided heart failure. And so that's what we're looking for, is right-sided. So let's go back to this question. 70-year-old guy admitted with right-sided heart failure. Which would you see with right-sided heart failure only? Okay. A is paroxysmal nocturnal dyspnea. Okay, so what is paroxysmal nocturnal dyspnea? For those who aren't familiar with P&D, as is otherwise known, that is where you're sleeping and all of a sudden you wake up feeling extremely short of breath and you sit bolt upright and are gasping for air. That's paroxysmal nocturnal dyspnea. Why does that happen? That happens because you're getting edema into your lungs, into the parenchyma of your lungs. So you're getting pulmonary edema. As you know, when you're laying flat, that fluid in the parenchyma of the lungs distributes. Okay, so it's not just on the bottom, because what happens when you have pulmonary edema and you're awake, you're sitting upwards. Gravity is forcing all that fluid down to your diaphragms. So you can breathe with the upper lobes of your lung because all the fluid through gravity is now settling at the lower parts of the lung. That's why on chest x-ray you'll see lower lung field pulmonary edema, because of the gravity assist. So that's why people sit bolt upright when they have paroxysmal nocturnal dyspnea. Okay, so is this a left-sided heart failure problem or a right-sided heart failure problem? So any kind of pulmonary edema is going to be a left-sided problem, because that is after the right-sided heart failure. So we know that our right ventricle isn't pushing blood up into the lung. It's just sort of sitting there in the right side, going into the liver and the belly and the legs and the JVD, not going forward. So paroxysmal nocturnal dyspnea is a left-sided heart failure problem, not a right. C, pulmonary venous congestion. We just talked about that. It's basically the same thing as pulmonary edema. You have a lot of blood just sitting in the pulmonary veins, pulmonary arteries. It's not going anywhere because of left-sided heart failure. Orthopnea, same deal, pulmonary edema. We're orthopnic, meaning we can't lay flat because all that edema is distributed throughout the parenchyma of our lungs. We have to sit up, allow gravity to push it down so we can breathe. So the correct answer for this question is B, increased jugular venous pressure, increased JVP, because the right side of the heart isn't pushing out all the blood that's receiving from the venous return system. So the backup is occurring into the superior and inferior vena cava, which is going up into our jugular vein, which we'll see as big ropey jugular veins on our patient. Okay. All right. Let's see. Let's skip to number 14. A 76-year-old female dresses in youthful styles, acts in a girlish manner, and asks repeatedly that she hates getting old, and states repeatedly that she hates getting older. According to Erikson's psychosocial development model, which state is she experiencing? And of course, when you get this question, you go, oh crap, I forgot this. This was back in freshman psychology. We haven't touched it since. So let's go over it real quick. Remember, with Erikson, each stage of life has its own developmental pattern. Oh, hold on, let me get this question here. Darn it. Oh, I'm so bad at this. Let me pop this up real quick. Say open image, new tab. There we go. All right. So again, we have crises at various ages, going from infancy to death, and they usually correspond to age. So the kiddie stuff we don't really worry about. So we for Erikson, we really should be focusing on the last three: young adulthood, middle adulthood, maturity to death. So young adulthood, 19 to 40, intimacy versus isolation. Basically, are you going to get hooked up? Are you going to start making families, or will you not? If you don't, it can lead to loneliness and isolation. If you do make relationships with both same and opposite sex partners, you feel more loving and have stronger relationships. Okay. Middle adulthood is more generativity, is what they call I can't pronounce it today, guys. Generativity versus stagnation. So that is where we have the need to create or nurture things that will outlast us. So you're at middle age and you're saying, youth has left me. I'm looking ahead and I'm seeing retirement and eventual death. What will people remember of me when I die? And people want to create something that leave a positive change that benefits other people, such as me doing the study guide. You could go to there. Versus failure, meaning that, I don't give a crap. Just whatever, being the grumpy old dude that doesn't want to do much of anything. So that comes to success versus failure in middle adulthood. And then the last one is age 65 to death, where we have ego, integrity versus despair, where you reflect on life. You look back on your life, I feel fulfilled, I feel that I have success, I created a family, I created a something that people enjoy, versus people who don't fail, or people who do fail at that, and want to go back to their youth and are bitter about getting old. So you would see your 70, 80-year-old cougar, I guess it wouldn't be a cougar anymore, that'd be kind of old, but dressing up in a little black dress, when she, you got a 5'4" woman who weighs 160 pounds and is 70 odd years old in high heels, that's kind of silly. But they're trying to recapture that youth that they lost. So that would be ego, integrity versus despair. So for studying that, I would focus on those three. If you do get that on the exam, it'll probably only be one question. But it is good just to review real quick so you can just, rattle off, the stages. All right. And so going back to that question, 76-year-old lady, youthful styles, which development stage? Most people would think it's identity versus role confusion. No, because that is at a younger stage. Identity versus role confusion would be adolescence, where they attempt to develop a sense of self and personal identity. Okay, that lady already has a sense of personal identity. She's just looking back at her life and saying, this isn't good. Industry versus inferiority, nope. Generativity versus stagnation, that's the middle-aged one. And then eager integrity versus despair. This is what she's at. So looking back on your life. All right. Let's go ahead a few questions. Negligence. Let's talk about negligence a little bit. So question number 17. When determining the burden of proof for acts of negligence, risk management would classify willfully providing inadequate care while disregarding the safety and security of another as A, negligent conduct, B, gross negligence, C, contributory negligence, and D, comparative negligence. Okay, so again, I know legal stuff. Fortunately, I'm married to an attorney. Even I get confused by this stuff. But I think the main takeaway is to know what to ignore and what to be concerned about. So when lawyers talk about negligence, here's a good article about negligence. All right. Especially with contributory versus comparative. Okay. Now, of course, this is an ambulance chaser website. So we're going to talk about contributory and comparative negligence. So contributory negligence in personal injury shifts a degree of fault to the plaintiff involved in the accident. So let's say, for example, that you're a nurse and you left, a 40-year-old guy that just had a cholecystectomy in the room by himself. He was hooked up to an IV on the opposite side of the bed from where the bathroom is. The dude got up, pulled the IV over, tripped, fell, split his incision open, and bled all over the floor and had to go back to surgery. And he's suing you because you didn't provide the IV pull at the right side of the bed. Okay, that could happen. The HR would say that is a contributory negligence because the dummy didn't wait for the for the nurse or the aide to come from the call bell and got up on his own and hurt his damn self. Okay, so how much of the injury is from the patient and how much is from the nurse? That is contributory negligence. Let's see, and then comparative negligence. That's if the patient is found to be partially responsible for his injuries. Again, fairly similar to contributory negligence. The thing they did here is if the patient is a DUI and hurt himself, how much did the drugs and alcohol contribute to his injuries? And they would give a percentage number. Okay. The main thing for you guys when looking at this, ignore both of these. Okay. That is not what HR looks at when they're looking at negligence. They're looking at the other two. So if you see contributory, if you see comparative negligence, I would say just ignore those or just disregard those because they are not, risk management is not looking at that. What they're concerned about is negligent conduct and gross negligence. All right, so let us look at these. And I actually have a good example. Okay, so when I looked up negligent conduct and gross negligence, negligent conduct is where an individual failed to provide reasonable care to protect or assist another. So this would be if Granny Gums came into the ED, she's 88 years old, had fevers, chills, rigors, and from the nursing home, and you did not check blood cultures in a UA, and she got septic and died. Okay, that is negligent conduct because you did not do the standards of care. Okay, when an old person comes in from the nursing home with fevers, chills, rigors, and looking like they're septic, part of the standards of care is you have to get cultures within 30 minutes. You have to start antibiotics within 30 minutes. That's a standard of care. If you don't meet that, that's negligent conduct. So versus gross negligence, and when you see gross, I mean it is gross. Like this is, I can't believe this person's in practice. Gross negligence is willfully providing inadequate care while disregarding safety and security of another. So this is just going off the ranch, being stupid. And I actually saw an example of this. I try not to be political, okay, but this has a little bit of political overtones. I don't get into that political crap, but I just happened to see this. So this is, again, if you guys are looking at this outside of April of 2020 with the coronavirus pandemic, this is a tweet that a nurse put out from a guy, who's a Trump supporter, and says, "My wife sewed this face mask today to protect me from the Wuhan virus and show support for President Trump." And on the picture, you have this old guy with a surgical mask that someone made for him, and it says Trump 2020 on it. They embroidered that. On the bottom, it looks like a nurse practitioner said, "I'll see you in the emergency department. Please wear your mask so when we have to decide who gets the vent, it'll be easier. Thanks." Okay, that is gross negligence. Okay, now granted, she and this guy will probably never, ever, ever have contact with each other. But if they did and that tweet went out, oh man, she would be sued to there wouldn't be anything left. She would be destitute and broken and on the side of the road. That is gross negligence, because we never, ever, ever talk like that. We provide care to everyone. All right. Sorry about that. My wife just called. Anyway, number 19 here. Which of the following tests is most accurate for determining acute changes in nutritional status to monitor dietary compliance for a 15-year-old patient with anorexia? Okay, so when we look at this, we have to understand how protein is made in the body. Okay, so we eat protein. Protein is broken down by stomach acids, basically transferred down to amino acids. Amino acids is picked up through this areas of the small intestine, then recombined back into protein chains. All right. So we're looking here. We have transferrin, which is a liver enzyme. We have total protein, so that's all the protein in our bodies. We then have prealbumin and albumin. All right, so all these are proteins, okay? But total protein and transferrin are affected by more things than nutritional status, okay? Because our transferrin status can be affected by iron, liver status, same with proteins, okay? So those two are gone. So then we have albumin and prealbumin. Okay, so we're looking for acute changes in nutritional status. So when we look at acute changes for just the past couple of days, we look at prealbumin. You have to have prealbumin, which is then changed into albumin. So prealbumin is good for acute changes. Albumin is used to look at chronic changes. So if you have an anorexic and you're looking at dietary compliance, if they're eating all their meat and potatoes, you should see their prealbumin levels come up before their albumin levels go up. If you have someone that is now suddenly not eating, you'll see their prealbumin levels go down, but their albumin levels will still stay up for a while. That's how you can tell if it's a chronic problem or an acute problem. So if you have an acute anorexic coming in, you should see low albumin and prealbumin levels. If you see someone that's just freshly, I'm not eating, and you're doing a nutritional check, albumin and prealbumin, the albumin levels will be fairly normal or low normal, and the prealbumin levels will be quite low. So that's how we can determine, is this a chronic change or a long-standing problem versus an acute problem. All right. And I think I'm going to stop there. I'm at 30 minutes. That's good. That's good enough to stop. That at least get me to work when I travel back and forth to the hospital. So you guys have a great one. I will try to upload another study group video as long as I can, or as many times as I can before I head back to the hospital. I would do week on, week off schedule. So I will try to get as many in as I can to help you guys out with your studying. If you guys have any questions about anything that I've gone over, please let me know. Again, if you're interested in this book, again, I'm just taking excerpts from it. I'm not reading the whole book. But if you're interested in this book, I've listed the Amazon link for this. I get no money from this. This is just, I thought it was a pretty cool book. Only $10 for Kindle readers, and it is a good one. So I'll leave it there for you guys. You guys have a great day. Talk to you next time.